Welcome to the deep dive. Today, we're tackling a really significant health issue, cerebrovascular disease.
That's right. Things like stroke, TIAs.
Exactly. We've got a stack of medical literature here, and our mission is to pull out the most crucial insights.
Kind of cut through the noise.
Yeah, give you the shortcut to understanding what really matters about stroke and these transient ischemic attacks, TIAs.
Okay. And we're going to look at, the history, how common it is, the impact.
The whole picture, and what the latest science is telling us.
It's quite a journey, actually, from early ideas to modern treatment.
Let's start there then, way back. It's almost hard to believe now, but the early understanding of stroke was, well, pretty different.
Oh, absolutely. People mainly thought it was just problems inside the brain itself.
Right, like bleeding or vessel spasms. Even big names like William Osler were focused there.
Yeah, the idea that the problem might start in the neck arteries, the carotids, wasn't really on the radar for many.
But there were clues, weren't there? Even earlier.
There were. Way back in 1875, a physician named Gowers, he noted a link. He saw that blocking the carotid artery could cause stroke symptoms.
That's pretty insightful for the time.
Definitely an early clue. And then fast forward a bit to 1905.
Chiari, doing autopsies.
Exactly. He found blood clots sitting right on top of that fatty buildup plaque in the carotid artery.
And people who'd had strokes caused by those clots moving to the brain.
Precisely. That seems to be the first really clear description linking carotid plaque to embolic strokes. A huge step.
But the name that really comes up for the big breakthrough is Fisher in the 1950s.
Dr. Miller Fisher, yes. His work was pivotal. He made those critical clinico-anatomic correlations.
Meaning he connected what he saw in patients with what was actually going on in their arteries.
Right. He specifically pointed to that atherosclerotic plaque in the carotids as the source for many strokes.
Wasn't there something about where the plaque was?
Yes, that was key. He noticed the disease was often in the lower part of the internal carotid, but the part further up, closer to the brain, was usually clear.
Which hints at surgery.
Exactly. If the blockage is localized and accessible, maybe you can fix it. It really paved the way.
And then came the actual surgeries. Eastcott et al. In 54.
Reported the first successful one, yeah.
And DeBakey, even slightly earlier, in 53, did the first carotid endarterectomy. That's the plaque removal surgery.
That's the one. And incredibly, his patient was symptom-free almost 2 decades later.
Wow. That's amazing longevity.
Truly pioneering work. But, single cases are one thing. We needed bigger studies.
Which came in the 90s, right? The big randomized trials.
Yes. Those were crucial. They really confirmed that CEA, the endarterectomy, was safe, effective.
And actually better than just medical treatment for many patients.
For many, yes.
Yeah.
Both for those who'd already had symptoms and even for some carefully selected asymptomatic patients.
So that cemented its place as a standard treatment.
It did, provided the patient is a good candidate, of course.
Okay, great historical context. Let's get down to the basics now. When we say stroke, what are we actually talking about?
So, a stroke or cerebral infarction is essentially a sudden brain function problem because blood supply gets cut off to a part of the brain.
And there are two main types.
Right. Ischemic, that's a blockage, like a blocked pipe. And hemorrhagic, that's a bleed, where a vessel bursts.
And ischemic is the most common.
By far. In the U.S., something like 87% are ischemic strokes.
And we've said carotid artery disease is a major preventable cause of those ischemic strokes.
Absolutely. Along with things like atrial fibrillation, that irregular heartbeat, and critically high blood pressure.
So if a stroke is related to the carotid artery, what might someone notice? What are the signs?
Typically, it's sudden. You might see weakness or numbness on one side of the body, the side opposite the blocked carotid.
Okay.
Trouble speaking is common, too. And sometimes temporary vision loss in one eye, the eye on the same side as the bad carotid.
That's quite specific.
Mm-hmm.
Now let's switch gears to TIAs, often called mini strokes. What's the deal there?
A TIA, or transient ischemic attack, is a brief episode. Neurological problems like stroke symptoms, but they resolve completely, usually within minutes, always within 24 hours. Function goes back to baseline.
Sounds less serious, but you said they're important.
Hugely important. Don't let mini fool you. A TIA is a massive warning sign.
A warning for what?
For a future, potentially much larger stroke. About 30% of people who have a TIA go on to have a full stroke within 5 years.
30%, that's high.
It is. And it's also worth remembering that even with a stroke, the full impact might not be obvious right away. It can sometimes take up to 2 weeks to fully manifest.
So a TIA is definitely a wake-up call. Get checked out immediately.
Absolutely. Urgent evaluation is key.
Now, thinking beyond the individual patient, what about the cost of stroke? To the healthcare system, to society, it must be astronomical.
It really is. Just looking at 2014-2015 in the U.S., the estimated total cost medical care plus lost productivity was around $45.5 billion. And projections. They showed direct medical costs more than doubling between 2015 and 2035, hitting over $94 billion.
Why such a big jump?
A large part is our aging population, especially the growing number of octogenarians needing long-term care after a stroke.
And looking even further out.
The projected total costs through 2050 are just staggering. Over $1.5 trillion for non-Hispanic whites, $313 billion for Hispanics, $379 billion for Black individuals in the U.S. alone.
Those numbers are hard to even comprehend. It really underscores why prevention is so vital.
Absolutely. The societal burden is immense.
So let's zoom out again. What's the global picture? How many people are living with stroke worldwide?
Globally, back in 2013, the estimate was about 25.7 million stroke survivors. And in that same year, 10.3 million people had their first stroke.
And the impact? Deaths, disability.
Stroke causes around 5.5 million deaths globally each year, and it's a huge cause of long-term disability.
And in the U.S., what are the key stats?
It's relentless. A stroke happens roughly every 40 seconds. That's nearly 800,000 strokes a year.
Every 40 seconds.
Yeah. And it's estimated maybe 7 million U.S. adults aged 20 or older report having had a stroke. The overall prevalence between 2013 and 2016 was about 2.5%.
And you mentioned silent strokes earlier.
Right. Silent cerebral infarctions. Small areas of damage, often unnoticed. Their prevalence is estimated anywhere from 6% up to maybe 28%.
So a lot of hidden damage, potentially.
Potentially, yes. And looking ahead, projections suggest the overall prevalence of stroke in the U.S. could increase by over 20% by 2030.
Mainly due to aging.
Primarily, yes. The aging population is a major driver.
Does prevalence vary much across different groups in the U.S.?
It does. We see differences based on age, definitely. Ischemic stroke prevalence climbs steadily with age in both men and women.
And ethnicity.
Yes. Prevalence is highest among American Indian Alaska Native populations, around 6%, then Black individuals at 4%, Hispanics at 2.6%, whites at 2.3%, and Asian individuals around 1.6%.
Okay, and risk factors play a role in who gets it too, obviously.
Of course. Your individual risk profile matters a lot.
What about the number of new strokes happening each year in the U.S.? The incidence?
We mentioned around 800,000 new or recurrent strokes annually. About 185,000 of those are repeat events.
And differences between men and women?
Well, younger women might have a slightly lower risk than men their age, but because women live longer on average, their lifetime risk of stroke is actually higher.
That's an important distinction. And racial disparities.
We see significant ones. Black Americans have roughly double the risk of a first-ever stroke compared to white Americans.
And has that risk been changing over time?
It's interesting. The Framingham Heart Study, which was mostly white participants, showed stroke incidence declining over the decades. But that same decline wasn't really seen in studies focusing on Black Americans.
So overall trends. Is stroke becoming more or less common? Getting deadlier or less deadly?
Well, currently it's the 5th leading cause of death in the U.S. if you separate it out from other cardiovascular diseases.
Yeah.
As for incidence, some studies, like in the U.K. and Framingham, and the Greater Cincinnati Northern Kentucky Stroke Study, suggested a decrease in recent decades.
But not all studies agree.
No. The Minnesota Stroke Study, for instance, found stable rates between 1990 and 2000, so the picture is a bit mixed.
What about more recent findings, like the Artery study?
The Artery study confirmed known risk factors: older age, male sex, Black race, hypertension, diabetes, heart disease, smoking. They also noted cholesterol-lowering meds seemed protective.
Do they see changes over time?
Yes. They saw a decrease in age-adjusted incidence in people 65 and older, but not in younger folks. And, importantly, a decrease in death rates after a stroke.
That points towards better treatment, maybe?
Likely, yes. Better acute care. CDC data from 2005-2008 put prevalence at 2.6%. The general consensus seems to be mortality might be decreasing thanks to better treatment.
But the overall burden is still expected to rise because of aging.
Exactly. And more recent Cincinnati data up to 2017 suggested recent incidence decreases were mainly in ischemic strokes in men, with rates becoming similar between sexes by 2010.
What about the role of managing risk factors in these trends? Any specific studies on that?
The Tromsø study from Norway gave us some great insight there. They figured improved risk factor control explained about 57% of the drop in ischemic stroke incidence they saw between 95 and 2012.
And what were the biggest factors?
Number one was lower average systolic blood pressure. Number two was fewer people smoking.
That's significant. What about cholesterol?
Surprisingly, they found changes in cholesterol levels didn't seem to contribute much to that specific decline in their population.
Really? That is unexpected, given how much we focus on cholesterol.
It highlights just how critical blood pressure and smoking are for stroke, doesn't it?
Absolutely.
Yeah.
But you mentioned conflicting data earlier.
Right. It's not all pointing down. For example, data from the nationwide inpatient sample showed hospitalization rates for acute ischemic stroke nearly doubled in younger men aged 18 to 44 between 1995 and 2012.
Doubled. In young men. That's worrying.
It shows that trends can differ significantly between groups. We can't just look at the overall average.
Okay, what about the global perspective from the global burden of disease studies?
The 2016 study showed a slight overall increase in ischemic stroke prevalence worldwide from 2006 to 2016, about 2.7%.
That increase.
While the rate was decreasing mainly in high-income countries, no real change in low- and middle-income countries, but the 2020 update was even more telling.
How so?
It found that while the rates of incidence, prevalence, mortality, and disability-adjusted life years all declined from 1990 to 2017,
Okay, that sounds good.
the absolute number of people affected by stroke worldwide nearly doubled in that same period.
Doubled. Because of population growth and aging again.
Precisely. So despite progress in rates, the sheer number of people impacted keeps growing. Stroke remains a top global cause of death and disability.
A huge global challenge.
Yeah.
Now let's circle back to medical therapy. How has that changed the picture for carotid artery disease specifically?
Well, those older trials clearly showed surgery beat the medical therapy of the time for severe carotid stenosis.
Right.
But medical therapy, things like statins, better blood pressure control, has improved a lot since then. So more recent analyses suggest the annual stroke risk for someone with asymptomatic stenosis might be lower now than reported in those older trials.
Making the decision about surgery versus medication trickier for asymptomatic patients.
Exactly. However, even if they don't cause symptoms initially, these carotid blockages still account for a lot of strokes. One estimate is maybe 41,000 strokes a year in the U.S. could be traced back to previously asymptomatic carotid stenosis in the neck.
41,000. That's still a huge number.
It is, and the exact role of cholesterol-lowering meds in this reduction is still debated, as we saw with the Tromsø and global burden of disease findings potentially conflicting.
Let's dig into that cholesterol link a bit more. You said it's inconsistent for stroke.
Yeah, it's not as clear-cut as it is for heart attacks, but a big meta-analysis did find that statins were linked to a 21% relative risk reduction for stroke.
Though mostly in secondary prevention, people who already had issues.
Many studies were, yes. But statins have shown links to fewer strokes in various groups. People with heart disease, high cholesterol, even normal cholesterol, older adults, diabetics.
And they help the arteries themselves.
Yes, they consistently reduce carotid intima media thickness, CIMT, which is a measure of artery wall thickening. And using statins around the time of a stroke seems linked to better long-term outcomes.
What about using them just for primary prevention? Healthy people.
The data's less conclusive there, but guidelines do recommend statins for primary prevention if your LDL is high and you have other risk factors putting you at high cardiovascular risk.
But specifically for preventing stroke in someone who already has severe carotid blockage.
That's where it's still less clear. The direct impact of statins in that specific high-risk group needs more research.
Okay. And you mentioned earlier that the decline in stroke deaths might be more due to blood pressure treatment than cholesterol treatment?
That's what the American Heart Association suggested, yes. Primarily better hypertension control. Study after study really hammers home that elevated blood pressure is the single most important modifiable risk factor for stroke.
It keeps coming back to blood pressure.
It really does. Just like the Tromsø study found controlling hypertension was the biggest driver of the incidence decrease they saw.
So let's list out the key risk factors for ischemic stroke. What should people be most aware of?
Well, the risk factors largely mirror those for generalized atherosclerosis, plaque buildup everywhere.
Okay.
Plus, having had a prior TIA or already knowing you have carotid atherosclerosis are major clinical risks.
And beyond those? Sex.
Stroke is generally more common in men, but women have higher mortality overall, partly due to living longer. Plus, there were some female-specific risk factors. In 2016, women accounted for about 58% of U.S. stroke deaths.
Age. We know that's a big one.
Huge. Risk roughly doubles every decade after age 55.
Race and ethnicity.
We mentioned Black and Hispanic individuals have about double the risk of a first stroke compared to whites. There's a theory that the higher rate in Black individuals might be linked more to hypertension and intracranial vessel disease rather than carotid disease, but that's still being explored.
And hypertension itself.
Massive risk factor for both ischemic and hemorrhagic stroke. Treating it effectively brings substantial risk reduction. Intensive control seems even better and helps prevent recurrence too.
Family history. Does that play a role?
Yes. If a parent had a stroke, TIA, or heart attack, your own risk is increased.
What about atrial fibrillation? AFib.
That significantly increases risk about 3 to 5-fold,
Right.
specifically for cardioembolic stroke clots from the heart, definitely. Current smokers have 2 to 4 times the risk compared to never smokers or long-term quitters. Quitting helps reduce risk across the board. One study in Black patients showed a clear dose response, more smoking, higher risk, but the risk dropped after quitting.
Okay. Cholesterol we've discussed. Lifestyle factors like activity levels.
Physical activity is protective, seems linked to frequency and intensity. Less than 4 sessions a week was linked to higher risk, possibly because exercise helps other factors like blood pressure and weight.
Diet.
Also important, high fruit and vegetable intake, Mediterranean-style diets, those are linked to lower risk.
Diabetes and obesity.
Diabetes is a risk factor at all ages, particularly potent under 65, almost doubling risk. Maybe even stronger effect in women. Interestingly, super tight glucose control hasn't shown a clear benefit for stroke risk reduction, though, and diabetes is linked to post-stroke dementia.
And obesity.
Yes, BMI over 30 is a risk factor. And abdominal obesity, that belly fat, is linked to ischemic stroke risk in men.
Alcohol. Always a complicated one.
It is. Irregular heavy drinking or binge drinking seems to increase risk, but some studies suggest moderate, regular consumption might slightly decrease it. A tricky balance.
Any other less obvious ones?
Kidney problems, even mild to moderate renal insufficiency, are an independent predictor. Lower socioeconomic status is also linked to higher stroke mortality, independent of other factors.
And COVID-19, that's newer.
Yes, it's emerged as a significant risk factor, especially in younger patients, probably due to increased blood clotting.
Wow, quite a list. Did the interstroke study try to boil it down to the most important ones globally?
They did. That huge 2010 study found that just 5 factors accounted for over 80% of the global risk for ischemic stroke.
5 factors. Which ones?
Hypertension, smoking, abdominal obesity, poor diet, and physical inactivity.
And the biggest single one.
Hypertension, by far the most important population attributable risk factor.
Really drives home where prevention efforts need to focus.
Yeah.
Now, if someone does have a stroke,
Right.
what are the outcomes? Risk of recurrence, death.
The risk of having another ischemic stroke after the first one is significant. About 2% within 7 days, 4% by 30 days, 12% by a year, and nearly 30% by 5 years.
That's quite high. And mortality.
Also substantial. Roughly 7% die within 7 days, 14% by 30 days, 27% by 1 year, and over half, 53%, within 5 years after an initial ischemic stroke.
Sobering statistics.
Absolutely. In the U.S., someone dies from a stroke about every 4 minutes. It accounts for roughly 1 in every 18 deaths. 5th leading cause overall.
And for survivors, what about long-term disability?
Stroke is the leading cause of serious long-term disability in the U.S.
What kind of disabilities are common?
Among survivors 65 and older, at 6 months post-stroke, you see high rates of hemiparesis weakness on one side. Many can't walk without help. Significant numbers need help with basic activities of daily living, like dressing or eating. Aphasia language problems is common, depressive symptoms too, and a substantial number end up needing institutional care.
That's a huge impact on quality of life.
Massive. And the CRESH trial showed higher 4-year mortality after stroke compared to those who had carotid intervention but avoided stroke. It's also linked to long-term cognitive decline thinking and memory problems, both right after and accelerating over the years.
We touched on recurrence risk. How much higher is it after an event?
Much higher. Population studies show recurrence rates climbing steadily, maybe 8% at 1 year, over 18% by 4 years in one cohort. Having more baseline risk factors and large artery disease makes recurrence more likely.
Like in the NASAT trial.
Exactly. Medically treated patients with severe symptomatic stenosis and NASAT had a very high rate of ipsilateral stroke on the same side within 2 years. And a Chinese study found over 40% recurrence at 5 years among stroke survivors.
Just to recap the death rates again.
Stroke causes about 1 in 20 U.S. deaths overall. Eric's study showed mortality increasing over time post-stroke. And CDC data for Medicare patients showed 30-day mortality really depends on age, from around 9% for 65-74-year-olds up to 23% for those over 85.
Okay, let's focus back on TIAs in more detail. We know they're warning signs. What else is critical?
Right, the mini-stroke. Symptoms usually last minutes, almost always resolve within 24 hours, but it's crucial to see it as a warning.
Even though function returns to normal.
Yes, because damage can still occur. Brain scans, like CTs, sometimes show small areas of infarction cell death even after a TIA where symptoms fully resolved.
And the symptoms relate to the carotid artery, if that's the source.
Correct. They reflect the territory supplied by the anterior circulation, so hemiparesis, sensory loss, language problems.
And that eye symptom?
Amaurosis fugax, temporary blindness in one eye. That's classic for a carotid source. Usually the eye on the same side as the affected carotid.
And these tend to be recurrent in the same pattern.
Often, yes. TIAs from a carotid source tend to be stereotyped, affecting the same area, unlike emboli from the heart, which can go anywhere.
How common are TIAs?
Incidence increases with age, varies a bit by sex and race, similar to stroke. Critically, about 15% of all strokes are preceded by a TIA.
So recognizing that TIA is a huge opportunity for prevention.
A massive opportunity, and the short-term stroke risk after a TIA is very high. One ER study showed 11% risk within 90 days, 5% within just 2 days.
Wow, that's it.
Yes. Self-reported TIA incidence is estimated around 2.3%, but the true rate's likely higher because people might dismiss symptoms.
So the key takeaway for TIA is future stroke risk.
Absolutely. That's the most important consideration. If it's linked to ipsilateral carotid disease, it's a chance to intervene.
Are there ways to predict who's at highest risk after a TIA?
Yes. Factors like age over 60, having diabetes, specific focal symptoms during the PIA, and the duration if it lasted more than 10 minutes all predict higher short-term risk.
And long-term risk.
Even for those who get through the initial high-risk period, the 10-year stroke risk is still around 19%. And remember, MRI studies show many events classified as TIAs actually involve small infarcts.
So any transient focal neurological symptom needs urgent checking for carotid disease.
Definitely. Because the risk of subsequent stroke is high for both initial stroke and TIA patients over the next 5 years. One study showed over 31% risk in TIA patients.
Okay, let's dive deeper now into the carotid artery atherosclerosis itself, the plaque buildup. How exactly does it cause stroke?
It's responsible for a big chunk of ischemic strokes, but the mechanisms aren't quite as perfectly mapped out as, say, coronary thrombosis leading to heart attacks.
But there are main theories.
2 main ones, embolization and hypoperfusion.
Embolization is pieces breaking off.
Exactly. Small bits of the plaque itself, or clots that form on its surface, break loose and travel upstream to block smaller arteries in the brain. This is thought to be the predominant cause of TIA and stroke related to carotid disease.
Like those cholesterol crystals seen in the eye.
Right, Hollenhurst plaques. That was early evidence supporting embolization.
And hypoperfusion.
That's reduced blood flow due to the narrowing. It's actually less common as a direct cause of stroke because the brain has amazing collateral circulation backup routes. It usually only becomes a major issue if you have severe blockages in multiple vessels.
So embolization is the main worry from carotid plaque.
Generally, yes. And the severity of the stenosis, how narrow the artery is strongly linked to stroke risk in symptomatic patients. That's why it's such a key factor in deciding about intervention.
But it's not just about the percentage of blockage.
No. Other things matter too, like the plaque's morphology is irregular, ulcerated, and the concept of vulnerable plaque that's unstable and prone to rupture or clot formation is a really hot area of research.
You mentioned transcranial Doppler, TCD, for detecting microemboli. Tell us more about that.
TCD uses ultrasound to listen to blood flow in the brain arteries, typically the middle cerebral artery. It can detect these tiny signals called HI, high-intensity transient signals.
And HITs mean clots.
They're thought to represent microemboli, tiny clots or plaque debris passing through. They're generally only seen when there's an embolic source like carotid plaque, and they disappear after surgery.
Does the frequency of HITs matter?
Yes. More frequent HITs correlate with higher degrees of stenosis and more irregular or ulcerated plaque. Detecting HITs might identify patients at higher risk.
Has that been shown in studies?
Yes. The ACS study, for example, found that asymptomatic patients with embolic signals on TCD had a significantly higher risk of subsequent stroke or TIA, especially ipsilateral stroke.
So why isn't it used routinely for screening?
It has limitations. It's time-consuming, requires a skilled operator. There's no great automated detection system. And in some people, the ultrasound just can't get through the skull well enough, poor temporal windows. So not really practical for widespread screening.
Makes sense.
Yeah.
Now, thinking about classifying strokes by cause, the TOAST criteria you mentioned, where does carotid disease fit?
TOAST categorizes ischemic strokes, cardioembolic from the heart, large vessel disease like carotid or intracranial arteries, small vessel disease, lacunar strokes, unusual causes, and undetermined.
And large vessel includes carotid disease.
Correct. But interestingly, even with extensive workups, the cause remains undetermined in a surprisingly high percentage of strokes, maybe 25% to almost 40% in some studies.
What was the traditional thinking on how many strokes were large vessel?
It used to be thought maybe 50%, but more recent population-based studies suggest it's lower, maybe more in the 29% to 46% range.
And small vessel disease might be more common than we thought.
That's what newer evidence suggests, yes.
Can you give some specific study breakdowns?
Sure. The Rochester Epidemiology Project found large vessel disease, cervical or intracranial, caused about 17% of first ischemic strokes. Cardioembolic was higher, around 30%. Lacunar, small vessel, about 16%. An uncertain cause was the biggest group at 37%.
And the large vessel group had the highest early recurrence risk.
Yes, at 30 days. The Greater Cincinnati study in 2005 found large vessel subtype in about 17% of all ischemic strokes, first or recurrent. Within that, carotid artery stenosis specifically accounted for 8% and carotid occlusion for another 3.5%.
Leading to that estimate of 41,000 U.S. strokes per year just from net carotid stenosis.
Roughly, yes, based on those figures. What's also fascinating is a study following asymptomatic stenosis patients. When they had strokes, a good portion weren't large artery strokes, but lacunar or cardioembolic.
So having carotid stenosis might just be a marker of general vascular risk sometimes.
It suggests that, yes, it's complex. We also see potential racial differences with some reports of lower large vessel percentages in Black patients, but high undetermined rates in both groups, possibly influenced by how often certain tests are done.
What about strokes where the cause is labeled undetermined? Could carotid plaque still be involved?
That's a key question. Studies looking at ESUS embolic stroke of undetermined source often find a higher prevalence of carotid plaque, even non-severe plaque with high-risk features, on the same side as the stroke,
Suggesting it could be the culprit, even if it doesn't meet the criteria for large vessel disease.
Exactly. It implies carotid disease might be underestimated as a cause. Taking all this together, the known large vessel cases plus the potential contribution to undetermined strokes, many experts estimate that at least 20% of ischemic strokes are likely related to extracranial carotid atherosclerosis.
At least 20%. Okay. So how common is carotid stenosis in the general population? Do we have numbers on that?
We do, though estimates vary. The Tromso study found some degree of ICA stenosis in about 3–4% of adults, increasing with age, cholesterol, blood pressure, smoking.
And higher in older adults.
Yes, another study focusing on older adults found rates around 10.5% in men, 5.5% in women. A large global meta-analysis estimated about 21% of adults 30–79 have any carotid plaque, and 1.5% have significant stenosis, meaning 50% or more narrowing.
1.5% globally. That's still millions of people.
Yeah, over 57 million they estimated, and increasing since 2000. A U.S. screening program found significant ICA stenosis, 50%, in almost 11% of participants, more common than finding new AFib or hypertension. Rates were higher in those with known heart disease or hypertension.
So screening might pick it up, but you said routine screening is controversial for asymptomatic people.
It is, because we need to weigh the risks and benefits of potential intervention against the natural history, which varies.
Are there known risk factors for having stenosis?
Definitely. Older age is huge. Male sex, history of vascular disease elsewhere, hypertension, high cholesterol, diabetes, smoking, they all increase risk. Data from voluntary screening also linked peripheral artery disease and aortic aneurysm to it. Healthy diet and exercise seemed slightly protective.
Any racial differences in prevalence?
Some data suggests highest rates in Native Americans than Caucasians, with lower rates in African American males and Asian females. But prevalence consistently rises with age across all groups.
And does having more risk factors add up?
Clearly. A study showed a strong dose response. The more modifiable risk factors you have, hypertension, hypercholesterolemia, smoking, diabetes, sedentary lifestyle, the higher your odds of having carotid stenosis. Each additional risk factor increased the odds significantly.
Okay, so it's fairly common, especially with risk factors.
Oh.
Now, the crucial part, what's the natural history for asymptomatic stenosis? What happens if you just leave it alone, perhaps with good medical therapy?
This is really the heart of the debate for managing asymptomatic patients. We know risk is high if you've had symptoms, but it's less certain without symptoms.
Why the debate?
Well, arguments against routine intervention include the idea that modern medical therapy might lower the stroke risk enough to make the procedural risks, from surgery or stenting, not worthwhile for many. Plus, stenosis degree alone isn't a perfect predictor of which plaque will cause trouble.
So interventions should be selective.
Very selective, only for asymptomatic patients thought to have a high lifetime stroke risk. And deciding that involves looking beyond just the percentage narrowing.
What else should be considered?
Things like progression. Is the stenosis getting worse over time? Is there evidence of silent infarcts on brain scans? What are the plaque characteristics? Is it ulcerated? Does it look unstable?
What did the big trials tell us about the annual risk?
Trials like ACS, NASCET, and ACST consistently showed about a 2% annual stroke risk for high-grade asymptomatic stenosis in their medically treated arms. Though statin use was higher in the later ACST years, even the REACH registry showed increased risk with 70% stenosis despite high statin use.
And progression, is that a strong predictor?
Yes, several natural history studies show stenosis progression is a significant risk factor for future stroke. The ACSRS follow-up found progression in nearly 20%, and those patients had higher stroke rates.
Do people with asymptomatic stenosis often develop symptoms later?
Some studies suggest they do. One study of medically treated severe stenosis found about 25% developed ipsilateral neurologic symptoms over time, many were strokes, and a good number ended up needing revascularization.
Even moderate stenosis can progress.
Yes, another series showed moderate stenosis often progressed to severe despite optimal medical therapy, OMT, and a significant number developed symptoms, even some whose stenosis stayed moderate. A Swedish study also showed progression and symptom development in older men linked to standard risk factors.
So it's not necessarily a benign condition, even if asymptomatic initially.
Not necessarily, no. It needs careful monitoring and risk assessment.
Are there other associated risks besides stroke from that specific artery?
Yes, having significant carotid atherosclerosis is a marker for increased risk of cardiovascular disease elsewhere and death from any cause.
Like the Tromsø study showed.
Right. They found a 3.5 times higher mortality risk. A large systematic review estimated cardiac mortality around 3% per year in those with 50% stenosis. A recent study confirmed increasing odds of developing other cardiovascular diseases as carotid plaque burden increased, even from minimal plaque to non-stenotic plaque to actual stenosis. New strokes also occurred in that cohort.
So it signals wider vascular trouble.
It often does. It's a systemic disease process.
Okay. Now, for symptomatic carotid stenosis, where someone has had a TIA or stroke, the management is clearer.
Much clearer, yes. There's strong agreement that intervention is generally appropriate because the risk of another event is very high, especially soon after the first symptom.
Let's briefly touch on the vertebral arteries, too. Cerebrovascular insufficiency.
Right. Stenosis at the origin of the vertebral arteries supplying the back of the brain might cause up to 20% of posterior circulation strokes.
And symptoms can come from the subclavian artery, too.
Yes, subclavian artery stenosis can cause subclavian steal syndrome, affecting arm and brain blood flow. Cerebrovascular ischemia can result from emboli, local clots, or low flow. Atherosclerosis is a common cause, just like in the carotids.
What are typical symptoms?
Dizziness, visual focusing problems, loss of balance are common with vertebral origin stenosis. Thromboembolic events can cause more defined strokes in the cerebellum or brainstem.
Okay, let's look at a few associated conditions. What about global cerebral ischemia?
That's a lack of blood flow to the entire brain. It's only a small fraction of ischemic events related to carotid disease, usually presenting with unconsciousness or near syncope.
What causes that typically?
Usually things like cardiogenic shock, severe heart rhythm problems, or cardiac arrest. Initial treatment focuses on the underlying cause. Sometimes, if there's isolated hypoperfusion causing asymmetric symptoms, treating proximal lesions like severe carotid stenosis might help.
What about lecunar infarcts? those small, deep strokes.
These are small infarcts in the deep parts of the brain, presumed to be from blockage of tiny penetrating arteries. Risk factors are typically hypertension and diabetes.
How common are they?
They account for about 20% of ischemic strokes. They often occur in specific locations like the basal ganglia or thalamus, causing classic syndromes like pure motor or pure sensory stroke. Many older adults might have them without symptoms.
Is there a link to the bigger carotid arteries?
It's controversial, traditionally viewed as small vessel disease separate from carotid atherosclerosis. But some recent studies suggest a possible link. Maybe small emboli from the carotid plaque traveling to those tiny arteries in some cases. The association isn't fully clear.
And cognitive decline. Is carotid stenosis linked to dementia or thinking problems?
Another controversial area. A systematic review found mixed results in non-surgical patients. It's hard to separate causation from association because dementia and carotid stenosis share many risk factors, like age and hypertension.
So the stenosis might just be a marker of overall vascular disease that also affects the brain.
That's one possibility. Silent brain infarcts or lacunar infarcts could be a link, but there isn't strong data directly correlating the degree of stenosis with the degree of cognitive decline.
Okay, we have covered a ton of ground today. From the history, the definitions, prevalence, impact, risk factors, all the way to the details of carotid disease and related conditions.
It's a huge topic. We've seen how understanding evolved from focusing just inside the skull to recognizing the crucial role of neck arteries, like the carotids.
And the importance of risk factors, especially hypertension, just keeps coming up.
Absolutely. Plus, the development of effective treatments like endarterectomy, proven in those big trials, was a major step forward.
But the scale of the problem globally, economically, is still immense.
It really is. And areas like managing asymptomatic stenosis are still evolving as medical therapy improves, and we learn more about plaque vulnerability.
So for you, the listener, what's the take-home message? I mean, it really seems to emphasize knowing your risk factors and managing the ones you can control, right?
Definitely. Blood pressure, smoking, diet, activity, those are key. And recognizing symptoms of TIA or stroke and seeking help immediately is critical.
It shows how far we've come, but also that stroke is still a major challenge, and research is constantly refining things.
Exactly. It's a dynamic field. Our understanding of how carotid disease progresses, how risk factors interact, how best to use medical versus surgical treatments, it's all still being actively investigated.
Which leads to a final thought. Given this complex picture, the variable natural history, the interplay of risks, the improving treatments, what do you find most compelling, or perhaps still most uncertain, about the future of preventing and managing stroke for people with or at risk of cerebrovascular disease?
That's a great question. Maybe it's pinpointing exactly which asymptomatic plaques are truly dangerous and need intervention versus those that can be safely managed medically. Refining that risk stratification seems key.
Finding that sweet spot. Something for all of us to think about. Thanks for joining us for this deep dive.